welcome to the Healthcare in a Nutshell conference. I'm thrilled to have you all here today. Thank you for joining for what promises to be an inspiring event. For those that don't know me, I'm Lana and I. I also go by Yourpharmasis on social media, and I'm currently a second-year pharmacy student at the University of East Anglia, and I'm deeply passionate about bridging the gap between real-world healthcare challenges and student education as well. So this conference was actually designed to give us all deeper understanding of the healthcare challenges that we face today and the ones that lie ahead in the future. And it's to allow us to begin considering how we, as future healthcare professionals, can deliver the best possible care. When I set out to create this conference, my goal was to offer students like myself a chance to attend an event that would not only help them connect with others, but also delve deeper into the issues shaping their field of study. I wanted to make sure that this opportunity was available to all students, regardless of their background and financial means. That's why I made this event free, because I believe every student deserves the chance to explore their passions and stay updated on the changes and challenges within their healthcare degrees. Today you are here, and this is the beginning of something special. Today marks the start of your journey as healthcare professionals who take the initiative, stepping outside the classroom to broaden your knowledge and shape your future. Let this conference be the first step in your exploration beyond university as you begin to see the bigger picture of your degree. Today is all about expanding our perspectives and sparking conversations on the real-world issues impacting healthcare. Now for the agenda of the day. You'll hear from a range of professionals, pharmacists, medical students, and physician associates, as well as doctors, who will share their insights on some of healthcare's most pressing issues. Together, we will explore topics that directly affect patient outcomes, workforce well-being, and the evolving needs of the NHS. Your thoughts and opinions on these matters are valued from a student perspective, and you will have the opportunity to also take part in these discussions by raising your hand and asking questions as well throughout the discussion. Later, we've got a networking lunch, so there will be free food, sandwiches, drinks, and snacks provided, and we've also prepared a interactive healthcare in a nutshell quiz. So there's really exciting prizes to be won. So let's see how competitive you all are. And finally, we have a goodie bags prepared for you as well, with our sponsor, Organised, who's kindly prepared that for you guys. And every student will receive that, and we have QR codes to give out as well for your certificates that we will be giving out, which can be used for portfolio and striving for excellence. So we'll be giving that at the end. I would like to give a massive thank you to my parents, who really supported me today, who are with me today as well, who partly funded this event as well, and they've been a great support system throughout this whole process. I'd like to extend a huge thank you to my contributors and supporters, UEA Pharmacy Society. And, of course, Revised Pharma, our sponsor of the day, for providing you guys with amazing goodie bags. So please can we also have a warm round of applause for him as well. I'd also like to give a special recognition to our talented photographer and designer, Ellen Wally. Not only will Ellen be capturing key moments on camera, but he's also created the event posters, all the graphics and promotional materials, which really brought this conference to life. And lastly, of course, UEA TV, who are with us today as a whole team, in capturing moments we can look back on and appreciate. So thank you to all our contributors and sponsors in today's Healthcare in a Nutshell conferences. Is everyone ready to start? Yeah. Okay. So we're going to begin introducing all our guest speakers. I'm excited to welcome each of our guest speakers on the stage. So they'll be sharing their expertise and perspective on today's key healthcare challenges. So, first off, we have a foundation year 3 doctor who shares inspiring and interesting stories From beyond the walls of the NHS with experience across various specialties, you may have seen his viral videos across social media titling Medical Phenomenon. Let's give a big cheer as we welcome Dr. Arthur. Okay, this is working. Dr. Arthur, can you just give us a little, how are you feeling today? How is it seeing all the students here?
Yeah, it's a lot of people. I don't see them online. Yeah, it's weird seeing people in person, but yeah, it's nice to see everyone. Thank you so much for coming, and thank you very much for arranging it. I'm incredibly impressed by sort of how many people have turned out. So yeah, I'm Arthur. I'm an F3 doctor. Do you have any medical students here today? A couple. But yeah, so basically, anyone who doesn't know what an F3 doctor is, I've completed medical school, completed F1 and F2 years that you have to do afterwards, basically just taking a year out before I then specialise. I've just applied to paediatrics training. The window for specialty applications are just closed. So yeah, hopefully starting that next year.
Amazing, thank you very much. Sorry, you can keep that. Right, so I think is everyone excited, by the way? Yeah. That wasn't, I need more energy, come on. Is everyone excited? Yeah. All right, keep up the good energy because our next speaker is a Foundation Year 2 doctor who went viral for his quick-fire questions with medical students online. You may know him as Med with Mo. Let's give a big round of applause for Mohammed Al-Badawi. We'll just take, no worries.
Hello everyone, my name is Mohammed, or Mohammed for you non-Arabic speakers. I'm a Foundation Year 2 doctor, so I think this year I'm applying for specialty training, and I started a social media page when I was in 4th year of medical school, and I think that's probably why I'm here today. So thank you guys all for coming.
No worries. Sorry, you can keep it. Okay, our next guest, I think we've got doctors, we need our physician associates. Get ready to give a huge welcome to an incredible physician associate working across 2 GPs who has written books that have reached over 2 million views with a background in biomed and a master's in PA. Let's give some noise as we welcome Zilan Wali to the stage. How are you feeling?
Guys.
How are you feeling? How is it to be here?
I'm good, thank you. Yeah, thank you for having us. I'm excited to shine some light on physician associates. I'm sure you've all heard a lot about us.
Yeah, okay. Thank you so much, Zilan. Okay, can I see how many pharmacy students are with us today? Wow, okay. Do we need some pharmacists on the panel? Okay. Okay, everyone, get ready to give a big welcome to a newly qualified pharmacist who has also ventured into aesthetics. You may also know her on social media as Tara's Touch, giving hope to many aspiring pharmacists. Let's make some noise for Tara El-Kaisi. Hello, Tara.
Wow, hi. So I'm newly qualified and I have been working as a locum pharmacist since September, 1st of September, so it's literally just been 2 months. But I'm excited to be here and thank you to Lana for organising this, it's amazing.
Thank you for being here. Wow, everyone here is qualified. Unfortunately, they're dealing with the NHS right now. I think we need someone who can relate to us as well as pharmacy students, as medical students, as biomed students, as healthcare professional students. Should we bring on a student? Yeah. Okay. Everyone get ready. Okay, that's the wrong one. Okay, everyone. Please put your hands together for a 4th year medical student at King's College London who intercalated at LSE. You may know him as Medicare on social media, and he's made it big and created platforms of his own such as MedVision, aiding numerous aspiring doctors today. Let's give a round of applause to Razi Missouri. Hello, Razi. Please tell us how you're feeling today.
Feeling amazing. Very excited to be here. Thank you all very much for coming. Didn't expect this many people, so yeah, hopefully having a great event.
Amazing, thank you so much. Okay, our next person is actually our sponsor today. So let's keep the energy high as we welcome a pharmacist and educator for the GPHC exam. He has helped many students pass their GPHC exams online and is here to share his expertise. Please join me in giving a big round of applause to Jar Saeed. Hello, Jar.
Hello. How are you all doing? It's great to be here. It was only 2019 where I was in your position, being a student here. So hopefully we can share on some insights on healthcare in a nutshell.
Amazing. Thank you very much. Okay, I want to ask, so doctors, pharmacists, Zilan, how are you feeling? Actually, you've got a mic.
I'm good, yeah. I'm just feeling a bit lonely. I think we need some more physician associates on the panel.
Should we bring more physician associates? Okay. Right, well, let's do it then. With a bachelor's in nursing and a master's in physician associate studies, she brings a wealth of knowledge and experience to the table working as a physician associate in dynamic GP setting. Let's give a huge warm welcome to the incredible Megan Werrett. Hello, Megan. How are you feeling today?
Good. How are you?
I'm very well. What do you have to say for our students?
Yeah, just thanks for coming out and just well done to you. You did all this, so yeah.
Thank you so much. We're really excited to have you all here today as well. So one of our guest speakers is actually running a bit late, so we will be introducing her later on. But last but not least, we now will introduce our final speakers for Healthcare in a Nutshell conference. They have had a huge impact on students' education, specifically aiding pharmacy students with OSCE help. Please welcome the one and only Leia and Sumaya from OSCE Toolbox. Guys, they haven't made it yet. Keep up the round of applause. Leia and Sumaya, how are you guys feeling today?
Good. It is amazing to be here and great to see you guys here. We're both still students as well, qualified and students. So we still come to things like this too. And it's great to see so many pharmacy students here today.
You want to say anything? No? Right. First of all, for our audience today, I think we should start off by introducing what everyone's roles entail. As some of our audience here today are not from a healthcare background, is anyone here not studying healthcare? Wow. Okay, amazing. So I think even for healthcare students, I think it's really important that we know what everyone's role is. Do we have any qualified healthcare professionals here today? Okay, everyone's students, all right. So if we can just go around and everyone just introduce what their role is, what their role entails briefly for our students here today. I'll start with Leia and Sumaya.
Hi, I'm Sumaya, so I'm a qualified pharmacist and I'm a third-year medical student now. I'm a locum pharmacist, so I do outpatient pharmacies, so in the hospital. So when people go to clinics, I do the pharmacy in the hospital, but that's not on wards. And I also locum in community pharmacy as well, and then, med student.
Hi guys, I'm Leah. I've done 4 years of medical school and I'm currently intercalating in a master's in healthcare management at the University of Leicester before I complete final year next year. And alongside that, I've done a lot of projects in medical education and now I run OSCE Toolbox.
Hi everyone, I'm Megan. So I'm a physician associate. I have a background in adult nursing. I was doing that for about 5 years in hematology and gastro, and then I went in to study physician associate. So at the minute I'm in GP and we work as part of the medical team. We're not doctors. We basically help in assessing patients, examining and forming a diagnosis, but always working under the supervision of a doctor.
Hello, my name is Gia. I founded Revise Pharma back in 2021. Did my pre-reg year, or trainee year as it's called now, or maybe even foundation year, always changed. did that back in 2019 in community. Then I worked for 3 years as a data analyst and then worked as a lecturer at university. And now I just do Revised Pharma full-time.
Hi, guys. They both work. I'll pick this one. Okay. Hi, guys. So my name is Razi. I'm a fourth-year medical student at King's, but I'm actually in my 5th year of university because I intercalated last year. So I did a master's in public health. So I've been at uni for a long time, but I'm enjoying it. It's been good. I like to call myself now a senior medical student. So I'm approaching the end of medical school. Next year is my last year, and then hopefully I graduate and become a doctor in the beloved NHS.
Hi, I am a locum pharmacist. I did my training in hospital and GP, but once I was done with that, I didn't want to go back. So I went into community pharmacy and I just locum. What we do is just like checking medication mainly, depends where you work. But you check meds, you see for interactions, you talk to patients. Now we have pharmacy first, but I'm sure we're going to go into that later. I think they're pushing pharmacists more to clinical side, so there's a lot more to pharmacy than just checking.
Thank you. Yep, so I'm Arthur, I'm an F3 doctor, which technically isn't actually a role, it just means I've not currently got a job, I just pick up locum shifts. I work mainly at the moment between A&E and acute medicine, all medical wards, so a lot of hospital work. However, during F1 and F2, which all doctors have to complete, I've done rotations in GP, surgery, A&E, and also medical wards. I trained in Nottingham, I've stayed up there at the moment, currently working in Chesterfield. Yeah.
Hello, everyone. My name is Mohammed. I'm currently an F2 doctor in my trauma and orthopedic surgery rotation. I graduated from UCL, it was actually last year, in 2023, and now I'm working as F2. I'm applying for specialty training this year. Yeah, you can ask me questions about that.
I've got one, Doreen. So I'm also a physician associate. I have been a physician associate for 2 years now in GP. I studied biomedical science and then went on to study the physician associate course. Like Megan said, so we work under supervision. So anything we decide to do with our patients, any decisions we make, we always have to run it by the doctors. This was meant to be really to help form as an extra addition to the healthcare team, just to help lessen or reduce some of that stress on doctors. So I love what we do, and I think as long as patients know what we are and what we're here to achieve, yeah, I think we do a good job.
Thank you. Can we give a round of applause? Is everyone happy with what the roles are today? Amazing. So now that we have a sense of everyone's roles, it's important to highlight all the incredible healthcare professionals that are here with us today, as they all work collaboratively as a multidisciplinary team to deliver the best possible care for our patients. For this part of the conference, please note that all questions and scenarios are open to the floor, as you audience will also have the chance to voice your own opinions and thoughts. So during the discussion, please also put your hand up and voice your own opinions. This is a safe place, and obviously you matter as well as students. And for the panel speakers, some of the questions are directed, however, they are open to all of you as well, so please add your own perspectives on that. Okay, let's begin our first discussion. So in the year 2023, Hull York Medical School conducted some research on the NHS workforce and healthcare professionals working together. It was found that healthcare professionals working in a multidisciplinary team often encountered communication issues, such as power imbalances, challenges related to equality and mutual respect. A question for all of you guys here today. In all your experiences, what is the most challenging aspect of working in a multidisciplinary team? Do you think this statement resonates with you, or are your experiences different to this? And can you also give a scenario in which you have faced this as well? So does anyone want to start? Yeah.
So I think when it comes to power imbalances, when I was working as a community pharmacist myself, the prime example was probably GPs. During COVID, the biggest issue was, okay, well, doctors weren't going to take in any patients to do blood pressure tests. but they just say, oh, it's fine, you can go to the pharmacy, they'll do it. And they don't realize, okay, but all these pharmacies, all these GPs were private practices. You can't tell patients that a different private practice will do a service without clearing it by the pharmacy first. So patients would come in and be like, well, the doctor says you do it. It's like, yeah, but, and I had to make it a very, very small kind of like, kind of metaphor for it. I used to kind of like tell people, well, you wouldn't really go to Asda to refund something from Tesco. And it's kind of like helping the patients understand the structure of GPs and pharmacies and actually point out that it is private contractors with the NHS rather than everything's owned by the NHS and there is some sort of hierarchy, is that patient education. And ideally we would, I feel like pharmacists would like a bit more cooperation from the GPs, especially most of the times it wouldn't even be the GPs saying that you could go to the pharmacy to get X, Y, Z. It would be like the receptionist there who, yeah, just, sometimes it felt like they were just passing it off to like make their lives a bit easier, but then it made a lot more trouble for us, which was fun during COVID. So there we go. My little rant.
Thank you for your perspective. Did anyone else want Dr. Arthur?
I was going to kind of agree with that. Doctors usually are the problem in the MDT. I've got to say, like, as far as power imbalances go, usually it's doctors in a way that are maybe a little bit more senior. Often the medical management, naturally, the doctor might be the same person on the team that sees that patient every day. So I think they do have a big responsibility to make sure the whole team is included and equally that the patient is aware of kind of where their treatment fits into the team, knowing that it's not necessarily just the doctor that's doing the medical plan, but actually there's a whole team of people. So I always sort of try and, in my practice, incorporate that and make sure the patient is aware that although maybe I'm the one who's seeing them face to face most days, there's a lot of other people involved. And equally, if I then, in this example, do ask them to go and see another professional, explain the reason for that, make sure with that professional that is a service that is running that kind of thing. But yeah, generally, I think accepting everyone in the team has a very equal and important role to play is kind of the main thing, particularly in hospitals when there's massive teams, because no one really feels like they know what's going on. So it's just important to always be transparent and open with things like that. Obviously, from a medical perspective, I think it's most people here are pharmacy. I think we've got any other kind of, so I've got a couple of medical, any kind of nursing students at all? Just to try and roughly aim this at. Cool.
Can I add something? I was going to say, in my experience in hospital as a pre-reg pharmacist, all the doctors were so lovely. There was like no problems at all. I was never like yelled at by, I feel like there's this big misconception that doctors will yell at pharmacists or like they'll tell you that you're wrong or something, but whenever you correct them, they're so grateful. Obviously, it depends on the hospital, like, some are great, some are bad, but I think it's more individual and if the doctor's just not a nice person. But in my experience, I've never had like a bad interaction with a doctor. Maybe like consultants, because, they've been working for years and years and years, and then I'm a pre-reg and I tell them something and I'm probably wrong and they're like, okay, shush. But otherwise, it's junior doctors are amazing. Most of the doctors are so amazing and they're so helpful. And it's one of the reasons I love hospital pharmacy, because you always have support. And whenever you need to question anything, you can not only go to pharmacists, you can go to doctors, you can go to nurses, and they're so helpful. So I think more positively, I've never had a problem with communicating and stuff, of course.
Yeah. And just from my experience as a medical student and the doctors that I've come across, I think it's a little bit difficult to kind of group all doctors into one label of doctor, because your experience really much, from my experience, depends on, first of all, how much value you offer them, and secondly, what stage they're at in their training. So if they're newly qualified or, quite recent in their trainings, somebody like Mohammed or Dr. Arthur, Dr. Mohammed as well, of course, they kind of appreciate, what shoes you're in, and they tend to be a bit more helpful. And of course, with the pharmacists, they're a bit more, they're a bit more pleasant to work with. Whereas I think when, you go higher up the hierarchy, I don't want to use that word, but I think it is a hierarchy. When you get to the consultant levels and that sort of thing, there is a bit more of a pride aspect of things. And it's like, I'm the consultant. How are you as a junior doctor, pharmacist, nurse going to tell me what's right and what's wrong? Which of course is bad. So I think, just to clarify, from my experiences, the label doctor is very, very wide. And it applies to everything else as well, of course. But I think especially with doctors, when you hear the stories on social media about like someone getting yelled at or someone being told to leave the room for whatever reason it might be, it, of course, varies depending on different factors.
So I've been working as a doctor for a year now, and I've already had multiple experiences. I think the main thing in the hospital is people who don't understand the structure. So like Vice Farmer said, so I had an experience with a consultant recently where he didn't understand how to do a referral because we changed the system, I think, a few years ago, but he's obviously been a consultant for so long. He ended up doing a wrong referral. We didn't see the patient because no one saw the referral, and then he ended up coming to the ward yelling at everyone. So it's mainly the senior doctors, senior consultants who don't understand the system, who kind of think that it's going to happen their way from like 20 years ago. I think the most pleasant people to work in the hospital are the other junior doctors and the pharmacists. Like, we really appreciate it. I've done a lot of wrong TTAs, and the pharmacists are there to correct it, so yeah. Oh, a TTA is to take away medications. It's the medications that patients take with them home. So we as doctors prescribe it, and then the pharmacists always check it. So yeah, we appreciate the pharmacists checking it because we need that.
I just want to ask, can you put your hand up if you did some kind of work experience before you started studying at uni? Okay, and can you keep it up if you did work experience in a different healthcare field, like shadowing someone in something else? Yeah, okay, cool. I just wanted to see that because I think a big part of kind of changing this culture and working in an MDT more effectively has to do with understanding the roles of other healthcare professionals. And this is something I think that medical schools do really well with GP placement. So have we got any medics in here? Medical students? Yeah. So have you had GP placement? And when you had your GP placement, did you have to shadow other members of the team? Receptionist, yeah. So usually when you have a GP placement, you'll shadow different members of the team, maybe the nurse, HCA, etc. And I think that's something that they do really well, and they do that on purpose so that you understand how everything works as a whole and what different team members do, what struggles they face, and how they depend on other team members. So I think just there's something to say for going out of your way to try and understand what other team members' roles entail and what difficulties they face.
Can I just add to that? Sorry. I know, so when we talk about, obviously, the team, this is more about the qualified healthcare staff, but obviously as students in healthcare, you're also part of the team. Based on my experience anyway, try not to take it personal if you feel the healthcare person that you're shadowing isn't giving you the amount of teaching that you feel you deserve. Just try to be proactive and just literally go around the team and find someone that's willing to teach you. I think that's quite important to take away as a student.
Yeah, thank you so much. Is that Dr. Yasmin? Sorry, can we please welcome Dr. Yasmin to the stage? No worries. Dr. Yasmin is a pharmacist in AI and engineering. Please, can we give her another round of applause?
I'm so sorry I'm late. Literally came from the bottom side of the UK. But hi everyone, have you all had a good time? Good.
Better now that you're here. Okay, thank you guys for all your perspective. What I'm taking from this is being aware of what the structures of the hospital are, basically. Dr. Arthur, you mentioned that communication is key as well, and you actually made a video on this, and mentioning that medical notes, you can't actually access patient notes that well. I think this may be probably a main factor in communication and miscommunication when it comes to dealing with patients. We actually have a video for that. If you haven't seen it already, this is Dr. Arthur. Oh, is the sound?
Nice to meet you. So you'll see from my GP notes so just to stop you there, so I actually don't have access to GP notes. Oh, well, it seems like it would be quite helpful for you to have access to them, but anyway. Yeah, no, it would be very, very helpful. So just start from the beginning and we'll go from there. Sorry to interrupt. It's 2024. Are my notes still pen and paper in hospital? Yeah, no, pen and paper is the system that we still use. All your notes actually will be in paper form. Some of it's digitalised, but it's not actually kind of alphabeticalised, if that makes sense. So it's very hard to find stuff. So what we'll do, write it in paper, put in your paper notes, that goes into storage, and then that's kind of how we access all your health information from a hospital point of view. That's crazy. You would have thought in this day and age, all your notes would kind of just be on one digital system where it was in chronological order from, I suppose, first to most recent. You had a past medical history, diagnoses, previous kind of significant investigation results, maybe even like medication history as well as allergies, things like that, all in one place that every healthcare professional can access, not kind of just certain aspects. But anyway, sorry, I'm
Thank you, Dr. Arthur. So obviously you've highlighted quite a big issue, and recently I was in one of my lectures and they actually talked about the universal system that they use, but even my lecturers were struggling to explain it. So do you think this is quite a prevalent issue in healthcare, especially when deciding next outcomes for patients? And obviously, do you think this is where the miscommunication happens between other healthcare professionals? What's your take on this?
Yeah, massively. I think, to be honest, it's probably the number one. I mean, it kind of comes under IT anyway, but it's probably one of the biggest issues, I think, just in healthcare in general. Often, so most of the context of my videos and where I'm kind of looking at stuff from is from a hospital setting, just because that's where I'm working the vast majority of the time. A lot of the time, I think when people are kind of disgruntled or feel like, for example, a doctor is kind of getting rid of a referral, unjustified, things like that. It's often not that they kind of can't be bothered or they don't want to do that work or something. It's often that system is just terrible. So a lot of our referrals are still paper. So if we want to get an echo done in A&E, we have to write a paper form, take it to the echo department. They then have to call a number. Bearing in mind, we don't really have phone other than the ward phone. It's just ridiculous. So often when stuff doesn't work very efficiently, it can come across as there's someone on the other end that kind of just can't be bothered or just isn't arranging it. Often it is kind of the case, I think, so I tried to portray in this video, where it's just a ridiculous system. If someone comes and sees me in A&E, I have virtually no context of who that patient is. I'm pretty much relying on exactly what they tell me. If, for example, and this does happen a lot, a patient kind of gets wind of that, they will come in saying they take morphine or opioids. You basically have no way to verify that. So often I will come to the A&E pharmacist and ask them to try and do a bit of a deep dive, because I don't really have any access to System 1 or a universal system. So often when it appears someone's being a bit obstructive, it can just be that the system is terrible. The best way to get through it is just communicating. So it always feels a bit embarrassing to go up to someone and ask them a question that's really obvious, or literally, can you access this system or find this out for me? But very quickly you'll realise that everyone has their own individual systems. Each speciality, each profession has their own systems. So in our hospital anyway, the medical notes, the physio notes, the occupational therapy notes, and the pharmacy notes are 4 different systems, none of which the other has access to. It's just crazy. So just that communication, being very transparent, you're bringing stuff to the conversation, even if it seems super obvious. It's probably not. It's probably stuff that I have no idea about because I haven't got access to that system. And yeah, there is a universal talk of universal healthcare. I think there has been since I started med school about 8 years ago. So it seems to be one of these things that's always on the horizon and never really seems to come to fruition. But it's a very crazy world in 2024. Yeah.
I just want to add, I used to work in this private hospital, and as a dispenser, I wasn't a pharmacist then. And one of our patients, so this private hospital was all paper-based, it wasn't computer-based. And one of the patients, she'd come in, she was being treated, she had a surgery, it was all elective surgery, so they were planned surgeries, not emergency. So she'd come in and, they had a drug history done and everything, and we had a locum pharmacist. She was brilliant. She was able to identify that the patient actually had cancer and was getting cancer treatment, but this was missed by everyone else because it was in paper. It was in folders beneath loads and loads of paperwork. So when she found out, obviously this was like a huge problem. But like what Dr. Arthur's saying, it is such a big problem because we can't access a lot of information, and no one has time. Like especially in NHS, you've got no time to look through piles of documents. So it's just really, it's bad. Yeah.
We see it a lot in community pharmacy as well, because in community pharmacy, we basically have no access to anything to do with that patient unless they've picked up medication from your pharmacy for years, then we can see it. We can access like a very brief summary care record, but nothing else. So we rely solely just on the patient telling us what's wrong with them and their past medical history. And when it comes to things like doing emergency supplies, like when they can't access a doctor and they have to come to us at like 9 o'clock at night for wanting medication, you kind of have to go off what the patient is saying a little bit and just trust everything that's on your system. But sometimes there can be gaps, like they haven't come to you in a year because they've gone somewhere else. So I think there is a big need for something a bit more universal so all healthcare professionals can access the same amount of information.
Thank you.
Yeah, I just kind of wanted to add on that. So, you know, you might think like, oh, there's not many innovators. Why has no one like just made a really simple system to connect all the healthcare data together? It's actually all to do with data, and so part of my role is I'm part of the NHS Clinical Entrepreneur Programme, which all of you guys can join as well, and I definitely advocate for that if you are wanting to start any kind of innovations. But when it comes to this kind of one full data set that people can access to see everyone's patient data, it actually focuses on who owns the data. And as we all know, patients should own their own data, and technically they do. However, each site, like care site, primary care, GPs, hospitals, they all have their own data sets, and they all see that that data is theirs, and they don't want to share it unless they're going to get something for it, i.e. cost, services, something. So they hold on to that data very tightly, and this is where we have this ambiguity, and obviously it impacts the patient the most, but this is where we have the ambiguity where people can't access or know what's going on, whether you're in community, primary, secondary, tertiary, private. There are more things coming out where, so there's this company called Patient Knows Best, where patients can actually request to hold their own data. In England especially, the NHS app is going to be the sole area where patients will have access to their own data and be able to show it to different healthcare providers. But it's actually literally to do with where that data is based and who owns the company where the data sits. And to be honest, they're not really going to share it. I can't see it in any time soon. So that's why it's better to devolve it to the patient so they can have that decision to then say, no, I want to share it with X, Y, and Z. And also, sorry, Lana, I'm taking it up a lot of time.
Oh, no.
But on top of that, there's actually a really big cultural thing as well. So generally in the UK, we're very distrusting of, apparently it's like a British thing, where we're very distrusting of our data being set in one area because of, you know, insurance companies accessing and saying, oh, you're going to get, your probability of getting cancer in the next few years is X amount, so we're going to charge you a premium, or, you know, a financial services not giving a mortgage application because they know when you're going to die, or whatever. You know, that's obviously extreme, but, you know, all of that data, if people have access to that, they can then really manipulate your life and give you access on the basis of you know, who you are, what you look like, what ethnicity you are, all of that kind of stuff. So that's why we're actually, as a culture, very pro having these separate systems, which, when it comes to healthcare, is detrimental to our care. But that's also one of the issues culturally where it's not really going to sync and link as easy as we might think.
Thank you. Does anyone else have any inputs they want to add? Any of the audiences?
Can I just add one last thing?
Of course.
I'll just say on the brighter side of things. So in my trust, I work in Northwest London, and in Northwest London, they've got a trust system where all the local hospitals share the same system. So we actually have access to all the patient notes from all their recent admissions to all the local hospitals, which is around maybe 6, 7 of them. We have access to their pharmacy records. There's something called London Care Records, where we can access all their drug histories and all that kind of stuff. And see what the GP had prescribed in the past and what's currently active. Though there are still problems, some patients come in from private hospitals, they come in from outside of London, and we can't access those things. But compared to the paper notes that I'm hearing about, it sounds like hell. So this actually was introduced last year. So when I started F1, it was all paper. Then a month in, we switched to a system called Cerner. So that's what we use now.
Yeah, and I think, Dr. Arthur, you mentioned in your caption, actually, in that video, that there was definitely a need for systematic improvements like innovations to help with the chronological order of how patient notes are. A question for Dr. Yasmin, as you are a pharmacist in AI and engineering. Is there anything in place right now for these systems to improve access to medical notes from a wide range of healthcare backgrounds for healthcare professionals? Is there anything in place?
At the moment, it really depends on what healthcare system you're part of. So as you can see from the diagram there, it kind of splits off, like you've got so basically you've got Parliament, which is the Department of Health, and then you've got NHS England, and then underneath that you've got things called integrated care boards, and they are patches of areas across the country which have actually the funding and have their hospitals, their primary care units, their general practices, their community pharmacies, their community care units under that banner. And so within an ICB, you can have a connected system like the London Care Record. But obviously, depending on which ICB you fall into or you live, they will have different kind of innovations going on. But there are a lot of clinicians trying to really connect the system. But it is very, very difficult because, like you mentioned, Cerner is a big player in the UK, which does electronic health records. But there's also Epic, which is another big player in the UK who does electronic health records. And they're two separate companies which are based in America, so they're not going to talk to each other. But even on a granular level, so for example, there's Epic, which is electronic health record, but they service different hospitals around the UK. But those hospitals are not allowed to share records between each other because they're like contained data containers. And so it's kind of like a GDPR thing and a data protection thing and all this other boring stuff.
Right, and I have a question for you. I think as an AI, someone who specializes in AI and engineering, I think there's a misconception that AI poses a threat to certain roles in healthcare, with some fearing it might eventually replace human jobs entirely. Can I just ask, has anyone ever had that thought that AI will replace your role? Yeah. Okay. Is this entirely false, or what's your perspective on it, Dr. Yasmin?
I think it's a really interesting question, but I always like to tell the story of Netflix. Does anyone know the story of Netflix? No? Okay, so basically, with Netflix, right, we use it all the time. Who has a Netflix kind of login? Basically everyone? Yeah, pretty much. Yeah, so basically with Netflix, right, it's a streaming site. How did they start? Well, initially, they started by posting DVDs out. And like back in the day, I don't know if actually you guys might be too young for this. Who used to go to the corner shop or Blockbuster to get their DVDs? Or knows someone who used to do that? Anybody? Yeah. So basically, obviously, we know Blockbuster existed. They were the biggest player, right? Then Netflix came along, and Netflix were like, well, actually, we're going to post CDs and DVDs to people's houses to make it easier so they don't have to leave their house. Great. They went to Blockbuster and they said, look, we've got a really, really great idea. We want to put these DVDs online so people can access them. And the head of Blockbuster was like, no way, that is never going to happen, never going to work. No one's even going to buy it. No one's even going to go for it. Like 30, 40 years' time, people are still going to go to Blockbuster to pick up their videos. What's happened now? Right? Blockbuster's in administration. Don't even know, it's been sold off, whatever. So this is it. We just moved with the times. So the same with healthcare and our roles, we're just going to move with the times. We're just going to have, now we're going to, rather than doing, the roles that were asked, like, if we think about pharmacy in general, okay, so my parents have a pharmacy. They've been in pharmacy for like over 40 years. My dad used to make creams in the back of his dispensary. Or now you get those creams pre-packaged. It's not part of the job role anymore. So we're just going to move with the times and upskill ourselves as clinicians, be able to support our communities, be able to, have people walk in, like we've got Pharmacy First now, where we can really support our patients, help the GPs with the loads that they have, and really kind of like, upskill ourselves in a clinical role, which was our initial kind of mainstay in the community anyway. So in answer to your question, I think we're just going to move with the times and upskill our role, and AI is going to be an addition to that. In terms of like regulation and stuff, there's a lot of regulation at the moment in mitigating just rogue AIs going, just being placed in different healthcare innovations. So that, I think, there will be like a scalpel is to a surgeon. Like, they will be an addition to us. They're not going to take over the whole role, because you still need human consciousness. I'm just going to do a little plug, actually. Sorry, Lana. So I have a podcast called the Pharmacy Podcast, and basically we interviewed a really amazing pharmacist last week, and essentially he was like, when you speak to a patient, and I'm sure you guys can all attest to as well, there's a thing called gut feeling, right? You might do all the, have all the blood results, have everything there, but when you're talking to a patient, you're getting that history, you have that gut feeling, which grows and develops as you become a better clinician over the years. But nothing can replace that gut feeling, not a computer, not a machine, and that's where humans will always be needed in the loop.
Thank you, Dr. Yasmin. Can we have a massive round of applause for that? I think that brings me to my next point, actually. So, Pharmacy First. Who knows about Pharmacy First here? Yeah, okay. So, Pharmacy First is some new services that are being provided as pharmacists. And like Dr. Yasmin said, is because now we have technology advancements that we don't need to be doing the roles that we did before. So now we can essentially help out doctors and other professionals in the NHS. A question for our pharmacists, but this also relates to other healthcare professionals. Recently, we've seen news about pharmacists voting to cut hours in protest over insufficient government funding. Has everyone in the audience heard about this as well? Yeah, okay. So for everyone here, can you explain sort of why is this happening? I know a similar thing happened with our doctors, with our junior doctors as well, protesting. Do you think this is kind of like a domino effect of seeing other healthcare professionals and then kind of following from that? Or is the NHS right now truly overwhelming, and roles that we saw as pharmacists are now changing to more hands-on patients and more like doctory roles type of thing? What's your take on this?
So I've been a locum pharmacist for 3 years, and I mainly work in community, so Pharmacy First is something new that's happened. I think what's happened is I don't think many pharmacists mind doing Pharmacy First. Like, I personally really enjoy doing it. It's more hands-on. I think the issue is coming from the fact that the job role has expanded, but we don't have any extra help. So the workload is still the same. And because it's very accessible to see a pharmacist, there's no booking appointments. I'll be checking, I'll be in the middle of doing methadone, and the dispenser will come and say, okay, there's someone here, they've got a sore throat. Nothing else, and then I have to get everything done and then come back out and see the patient. And because we don't have like allocated 15-minute slots and stuff like that, it can get quite overwhelming. So the issue, I don't think, is us doing the Pharmacy First, is the fact that we're doing it, but there's no other support, which is why I think people are like protesting a bit more. It's because it makes it harder to do your job and do everything safely. And as much as I would like to spend all my day seeing patients, I still have a whole dispensary to run as well. And especially when you're a locum, sometimes, like, I don't locum in the same place very often. So each time I go in, it could be a new system, new people, new patients, and you're also having to get used to that as well, on top of doing everything else. So I think that's the biggest issue, is the fact that there's no, like, you're just adding and adding and adding to the workload instead of, okay, you can do this and someone else can manage this in the back. So that's what I find personally in community.
Yeah, and I was going to say also, so I think the article about so it was the National Pharmacy Association that started this whole movement, basically. And the reason is that pharmacy owners were struggling with the prices. I think it's something to do with Brexit or something. I don't know, it's political, I'm not into that. But it's like, because now they're paying more for drugs but not getting reimbursed the same amount, so they're losing money per item. So I think that's why they're requesting funding. But I also agree with Sumaya, because it is very difficult to do things safely, especially because Pharmacy First is such a long process to fill out, because obviously we're not doctors, we're not diagnostics. I feel like there's a lot of push for pharmacists to become diagnostics and like do all the work that doctors don't have time to do, or like, because they're really pressured as well, and we're pressured, and we're pressured in a different way. We're doing other things. We still need to check, and if we don't have time to check, then there's going to be mistakes, and there's going to be like problems. Patients are like, there's so many pharmacies that are shutting down as well. I saw that the article about the Pharmacy First asking for funding. The guy that was doing the talk was saying that there was this one city that had completely closed all its pharmacies down now because they can't afford to stay open. So people are having to commute to other pharmacies. And you guys know how like busy Boots is. Like Boots alone is like crazy busy. So yeah, like I guess that's what we think about Pharmacy First. And also the training is not that great. I'm just gonna, like, it's online training, and it's I don't think it's that in depth. Maybe independent prescribers that are coming out now, they'll have better training, hopefully. But for people who have graduated without prescribing or any of this, I think it really needs more training. Like, they need better training.
Cool. On the topic of independent prescribers, the pharmacists who are independent prescribers working in pharmacies, they used to be able to offer that as a service. So you'd come into the pharmacy and be like, yep, I'll diagnose you, do the prescription, £40, private service. Now, if that was for like a UTI for someone that fits within those PGDs, now you don't charge them anything. You can just do it for free if they're receptive to free prescriptions. But then someone who will not be in that specific patient category, who is eligible for it, will come in and be like, oh, I want to be seen through Pharmacy First. And you're like, no, you can't, because you're not part of that specific group. And then you'll be like, well, we have to charge you. And then it's a matter of like, why are you charging me? So it's quite frustrating when you introduce ways. I mean, it's great for the community, yeah, more free healthcare for everyone. But then it becomes a matter of like, the pharmacists are always seen to be the people collecting the money for the prescriptions in the first place, where we only get £1.20 of it. And then now we're trying to charge people to do services that we were able to do when we can't give people Pharmacy First, because they just expect it to be free now.
Yeah.
Oh, sorry.
No, it's all right.
Oh, are you sure?
Yeah.
Oh, sorry, I was just going to say. So, yeah, what these guys were saying is perfectly correct. And so with this, guys, I've been a pharmacist for like 14 years, so you can tell, right? Like, I'm literally like dated. But yeah, so with the funding vote, essentially, it's what my colleagues have saying that. So the way that the pharmacy contract works is the pharmacies themselves, whether you're independent or Boots, you buy your drugs from the wholesaler, so you have to buy that off your own money. Then a patient will come in with a prescription for whatever it is, you give them that medicine, and then the NHS reimburse you. But they have a list of what they're going to pay you for that medicine called the drug tariff. Now, if you've bought that drug for more money than what the drug tariff is going to pay you, you're going to be at a loss. And this has continually been happening where the drug tariff is, the payment is way less than what you're buying the drug for. This has been continually happening over the last decade, I would say. So that's one of the issues. And then what also happens, like you were saying, with Brexit, we've had to, because of the import charges, all that stuff with the Suez Canal, do you guys remember? Yeah, all of that stuff. Basically, that's hiked up the drug prices. So then we still have to buy medicines for our patients because our patients are not going to return to us if we don't give them the medicine, but we're buying it at an inflated price. And on top of that, as medicines become of short supply, say like a manufacturer's like, oh, I only made 50,000 of aripiprazole, they're selling it to the wholesalers. So if you've got a patient that's on that, and then that's the last packet left in the UK, that wholesaler is going to charge you triple more than the amount. Like, for example, I think a while ago, a few years ago, you could buy atorvastatin for £1. It hiked up to £20-30 at one point, but the drug tariff price is still £1. So imagine that loss, it's huge. So that's one of the things to do with buying and selling in community pharmacy. And then also you've got kind of Pharmacy First, which is bringing more people to the pharmacy. You've obviously got kind of the rules that you're allowed to service patients within that. But then pharmacists have also had to kind of diversify their assets, so going into more private services. So that's where kind of these independent prescribers come into play. So for example, in our pharmacy in particular, anyone that doesn't fit in the Pharmacy First category, we do them a private consult. And do you know what? Patients are actually happy to pay. because they want to get that treatment there and then. And I feel like we're getting into this time now where nobody has time to wait for kind of a general practitioner appointment, which is going to be 2, 3, 4, 5 weeks, especially if you've got tonsillitis or something like that. Patients are just happy to pay. But this is kind of, the funding is also, it's about the drug tariff prices, but it's also like, because if you sell private services, you're then kind of isolating people that can't afford private services. So we're saying to the government, why don't you just support us to be able to support our patients that are vulnerable and need the access and can't afford the private services, rather than forcing us to charge everybody and just turn completely private, basically.
Thank you so much.
That was a
Thank
lot.
you for everyone's perspectives. Can everyone hear me okay? Okay, perfect. We'll move swiftly on to our next topic. This one is quite sensitive. It takes center stage, this one actually. For those of you who are not familiar with physician associates, also known as PAs for short, they bring incredible skill and dedication to their work. In primary care, they are experts in diagnosing and treating patients, offering personalized care that makes a real difference. In emergency medicine, they are quick thinkers, making critical decisions under pressure to ensure the best outcomes. When managing chronic diseases, PAs are committed to guiding patients through their care, helping them achieve better health with every step. Unfortunately, for both doctors and PAs, there is a constant comparison of the two professions, with criticism online, including various articles published by the BMA, the British Medical Journal, and the British Medical Association regarding physician associates and their work ethic and their ability to deliver safe patient care, and the need for potential discontinuation of the roles of PAs. For our physician associates and doctors that are in the room with us, please can you first clarify the difference between your roles? And thank you. We are joined here by 2 PAs today, Zilan and Megan. First off, I know this topic is quite sensitive, so please feel free to answer the questions you are most comfortable with. And also, thank you for coming out today to shine a different light onto your profession as physician associates. Can we please give Zilan and Megan a warm round of applause?
Thank you, guys. Yeah, I thought it was quite important for us to be here this week just because of everything that's been on the news. Have you guys seen the news on PAs? Do you know what PAs are? No? Okay. So like I said earlier, so we're a part of the healthcare team. We've not been around for as long as the rest of the team. We're more known in America and Canada. So we were brought around just to help to reduce some of that strain on doctors. So again, we do not practice the way doctors do. We don't make our own decisions. We always have to run it by a senior, which would be a doctor. So me and Megan both work in GP, and we have a supervisor that's always there. So towards the end of our clinic day, we have a list of patients that we've seen. So even though we've got the decision making in our head, we always just speak to our supervisors and let them know what we've decided to do. Most times than not, we completely agree with the decisions that we've decided to make, but sometimes if there is something that we've missed, it's just good to be, reassuring. But also every patient we see know that we're not doctors, and some of them get a bit worried, especially if they're new and they've seen the news. But again, it's all about reassuring the patient. It's about coming up with a management plan together. And oftentimes, really, it's just about, making sure that the patient's happy leaving the clinic room. I think that's pretty much it. Just really working to ensure that a patient is safe. I think that's our main goal. Unfortunately, the news is not been great. It's put a lot of pressure on us. It's not fair, obviously, on the healthcare that we're in as well, on our team, on our colleagues. Megan, anything?
Yeah, I think that's pretty much it. Obviously, the news reflects the bad aspects of us. And same with every profession, it might only be a small percentage of people who, are not been supervised or not practicing within their limits, which obviously is never recommended. And yeah, we're both in hospital and GP, and a lot of these stories are a mix of both. But all we can really do, our main thing that we do at the start of every clinic, start of every kind of consultation, is informing patients we're not doctors, this is our role, and kind of just patient education. I think that's the main key for us.
Yeah, thank you so much, both Zilan and Megan. So dealing with a lot of criticism can be quite challenging, especially if you lack the support from your own peers and healthcare professionals. What is this main criticism? What is it with, sort of peers and doctors, and please doctors, even med students, if you have your own opinion on this or your own perspective when you have been working with PAs when you have been working with doctors, what is sort of the clash, or is this just a different narrative that is portrayed online? What is it like in the workplace? What is your own experiences, and how do you navigate these criticisms that is constantly put on social media?
Honestly, I'd say it's all about knowledge and awareness. So I think when I was a student, none of the doctors knew what a PA was. So I think, obviously for them it's a bit nerve-wracking as well, because you're there, you're part of the healthcare team, and then you see the news, you are going to be a bit reluctant. I don't know how the doctors here feel. Luckily, no, I've had a lot of good support from my colleagues. The doctors are amazing. I think because we're all here to achieve the same goal, which is to make sure that the patient's safe, we're treating them, they are coming to us at the end of the day, being very vulnerable. I think for the doctors that I work in, for them honesty is important and communication. For us, it would be more risky if I just made my own decisions and didn't run it by them, or they're always happy to help. Sometimes I think it's just a little bit more pressure in the sense that obviously I don't want to bother the doctors as much, but at the same time, they know that we work under supervision, so they're always happy to help.
Yes, so in GP, we do have constant support, but obviously, I'm sure a lot of you have encountered when you go to your GP, sometimes you see locums. Just like personally, most locums are perfect, but if they're not educated on PAs, there's a lot of animosity towards us. I think I've shared a few stories already with Zilan and Lana regarding like certain locums, if they don't know of us, that we've literally been told, don't speak to me, don't even say hello to me at times. Personally, I've been told that. Like no PA is to even acknowledge me, basically. But I think, again, it's just all relays back to education and lack of teamwork.
I just wanted to ask, because I don't know much about PAs either, what are like the limitations for PAs like compared to doctors? Like, what is the training that PAs do that doctors do that PAs maybe don't cover?
So you have to do a 3-year undergrad healthcare science background, and then you go on to do a 2-year master's course. So we also train to the medical model, but I'm assuming it wouldn't be as specific. Ours is more of a general medicine. So we're here to treat the more minor illnesses rather than acute.
Okay.
Yeah.
I think from my experience as a doctor, I've only had good experiences with PAs. Obviously, as PAs, like you just said, you'll get a lot more when you're actually working, but I do think a lot of the narrative online is pushed by quite a small amount of medics. Personally, I don't really meet that many medics that have that stronger views against PAs. If anything, it's much more the other direction. In the hospital I work at, there's PAs pretty much on every ward, has a PA. The admissions unit, ED, has sort of 5 or 6 that rotate, just shifts like everyone else. I think the difficulty comes when the trusts who are managing the PAs don't give them the supervision and the correct guidance that they should have. I think it's quite a well-defined role for the PAs themselves, but actually the people managing it sometimes take advantage of that. So things like using a physician's associate in minimum staffing when that should be a number of doctors. So a ward may have to have a minimum of 2 doctors, and if there's a doctor and a physician's associate, that's unfair on the PA because it's putting them in a position where they're having to work beyond, what they're comfortable doing. It's very, I've certainly never come across it. There's the fleeting case in the news of, a PA doing something they're not meant to, but actually I've never come across it where they'll put themselves into that situation to try and go beyond their competencies, do things that isn't appropriate. The odd case on the news, you could argue that with any profession, and there's always going to be somebody who's going to do something that's inappropriate. Just look at doctors, the amount of people that get, and anyone's going to be doing stuff that is beyond their competencies. But for some reason, I think whether it's medical gatekeeping from the kind of medical community, it does seem to be there's this real push to find those examples of the odd physician's associate and kind of make them the example. But by and large, I've had very, very good experiences, and often the PA will be someone who's on that ward for maybe 2-3 years at a time, or as we rotate. So the PAs I've worked with on a gastro ward, they were teaching me how to do acidic drains, they were teaching me how to do fibro scans and all the kind of specialist things. To be honest, within their speciality, they were acting probably to the level of a reg in terms of knowledge. However, it's the sort of the diagnosing and the management that then falls back to the doctor. I think as long as that's a very well recognised boundary, which it is certainly from the PA side, it's usually from higher up that makes the issues really.
Just to play devil's advocate and to give the perspective of a medical student who can very much sense what other students around me are feeling, I think for some reason, not for some reason, we kind of understand why, because of limited jobs and that sort of thing. Medicine is a very, very, and healthcare in general, but I think especially medicine is a very, very competitive course. I'm sure you guys have heard of the word gatekeeping. It's a toxic thing. It happens at every medical school, some places more than others, and it doesn't help anybody. It's very counterintuitive, but it's a thing. And a big reason as to why a lot of medical students tend to gatekeep and be quite to themselves about what they do, what they get up to, and lie about how much revision they've done, what research they've done, and whatever. Because we know everyone lies. It's a fact. We all know this. I think the reason why they do that is because there's a lot of uncertainty around the future of doctors at the moment in the NHS. Now, if you were to compare the moment right now to maybe, let's say, 10, 15 years ago, I was high school, primary school, whatever I'm not really sure. But I think especially recently, and I think I'll talk more about this in a moment as well, with, of course, bottlenecks in training pathways and the lack of consultant jobs, and people who are very, very qualified. Me and Dr. Arthur were speaking about this earlier. People who are very qualified not being able to, progress in their careers because of just shortage of spaces. Medical students who perhaps don't have all the educational PAs that they should have are then assuming that they're taking their jobs. As blunt it is, as simple as it sounds, that's what they're assuming. That's what's being kind of propagated to them in the news and that sort of thing. And so it becomes a bit of a competition again, which of course isn't the right way, because they're not there to take jobs. We're not there to take their jobs. It's not how it works. We're all meant to be working together, right? And my experiences of being on placement, especially given that I took the year out last year to do my master's, I've come back and I've really, really noticed what the MDT means. It's a cliche thing, but it's very, very true. Being on placement 5 days a week now, I'm really noticing how important everyone is. And I was with 2 PAs. I think it was last week. We were together for the whole week. And it was incredible. We were bouncing off each other. We were learning so much from each other. There were things that I knew that they didn't know, and vice versa. And the patients actually enjoyed having us there, because we were there able to communicate together for the end purpose, which is what? To optimize patient outcomes, right? And that is the most important thing. And I think sometimes we overlook these things because we think about ourselves and about career progression. I want to be a neuro-oncologist or whatever you want to. That's not the point, is it? And I think that's where it kind of goes into a gray area, because people are like, what's the focus here? But that's just a little bit of a medical student perspective, because I don't think everyone's as mature and as understanding as the doctors and the professionals that we have here right now.
Yeah, and I just want to say, when I was on F1 last year, I first worked with a PA when I started my vascular surgery rotation. And Dr. Arthur put it perfectly. The problem isn't the PAs, that's what the news is saying, it's the trust. So the PA that I worked with, I even made a video about it. She was really, really good. She knew exactly what she was doing. She was teaching me things. I was 2 weeks into vascular surgery. I only ever did a week placement in vascular surgery throughout all of medical school. So I had no idea what I was doing. But then she was there for months and months. So she was teaching me. And again, some days would be minimum staffing on the ward, but then they would count her as one of the doctors. But then she would be annoyed at that because that's unfair for her. And so to other people who look like, oh, now this PA has taken the doctor's job, but actually it's a trust putting more workload on her. She doesn't want that. She's very annoyed about it as well. And that's the problem I think that's happening right now. It's not that they're actively taking jobs. No one's doing that. Everyone wants more help. So when I go and there's a PA there, it's actually very helpful. But when they're trusting that it's okay to replace a crucial member of the MDT with another crucial member of the MDT and give them double the workload, that's where the issues arise. So that's the issue that I've been seeing mainly. And it's just, unfortunately, the news, people don't know about this. They just think, oh, now there's one doctor, one PA on the ward, she's taken her job or whatever. So unfortunately, that's the issue. And on the first day when I started working, she was very clear. She was like, okay, this is what I can and can't do on the ward. When I need to prescribe something, you're going to have to do it. I can't order, for example, an X-ray because I think ionizing radiation, you can't order. I was like, cool, whenever you needed something, she would just come to one of the doctors, and there was never a problem.
So yeah, just to add, that's another thing. So we should know what medication, requires based on the condition of the symptom, and we should know what scans to order, but we're not allowed to actually order the scan. We always have to ask a doctor or another healthcare professional who can. Likewise with medication, we can't prescribe it, so we're not allowed to actually send it off. We don't have the right. We always have to run it by a doctor first, but we should know what medication is required for the condition.
Yeah, and I just want to add for PAs, even though we work GP hospital, there's a lot of controversy as well around the pay bracket and newly qualified doctors. But for us, we can't progress really in terms of pay or further education. Yes, we can go into like specialist areas and like do like the fibro scans and stuff, but pay-wise, we're really, really limited, so we can't really progress any further in a sense. And as well as that, because of all the controversy, I think it's going to be a bit limited as well what we can still do in the future. I think we're just kind of stuck in a sense at the minute. But yeah, we just have to see, I guess.
Thank you, guys.
I think someone has a question, sorry.
Yep.
What sort of regulatory board are they held to, if any? Obviously, there's a big issue with who takes the liability as they're under the consultants.
Did we get that?
Sorry, I can't hear you really well.
The regulatory bodies for...
Oh, right, okay. So we're a part of the FPA, so we don't have a GMC number yet, but hopefully that's coming into place next month. So at the moment, we're not regulated, which is why we can't send off prescriptions. But hopefully once we get registered with the GMC, which fingers crossed would be next month, because they've been saying for the past 2 years that we will be regulated. Once we have that, hopefully we'll have some prescribing rights and a bit more support in the role that we're doing at the moment. Yeah.
Would that change, do you reckon, anything at all in regards to sort of the study that you guys have provided? And like would it be more like prescription and stuff, like orientation?
I think what we'd have to do as an addition is probably prescribing course, because even though we've done a little bit of it as part of our degree, it's not enough to cover us to completely write off prescriptions, if that makes sense. I don't think there's anything else, from my understanding, that we need to do as an addition, because it's not like our role will change. It's just that when we get regulated, we'll just have protection the way pharmacies do, the way doctors do. Because at the moment, we have absolutely no support in the sense if we make a mistake, there's nobody to protect us, so we'd pretty much just get fired.
We do get indemnity cover is the only thing, so we are like insured in a sense. But it's still not perfect until we're under GMC. Yeah.
Sorry, does that answer your question?
Yeah. Amazing. I think we have another question.
Yes. So you already mentioned that realistically the fault for sort of mishandling and miscommunication around the PA situation falls under trust. So from your perspective, is there a realistic way to change that and to allow for everyone, PAs, doctors, and medical students, to have opportunities to learn key clinical skills without sort of arising the feeling of competition or creating unpleasant attitude in the workplace?
Yes, so I think the short answer is yes, there's definitely a solution. I think the issue with the NHS that certainly talking about competition ratios and stuff. So I've just applied to paediatrics, which each year gets a little bit more competitive, it's about 5 to 1 at the moment. Everything is bottlenecking, and what's happening is people are getting more and more qualified and basically just stagnating at a certain point in their career. I think the big issue at the moment is there's no foresight. Certainly it seems from the NHS to put out training posts, to commit to saying we're going to take you as a doctor and train you for the next 10 years to become a consultant in this. What's then happening is they are having people go to Australia, people who are just doing other things. I am one of maybe 5 people in my kind of extended medical friendship group who's not gone to Australia. And there's actually then a shortage of service provision. So what they're then having to do is fill that with roles that aren't doctors, but then they're not getting the training. And it's basically just getting into snowball effect where we're getting more and more people who are behind where they kind of should be in their training. I think what needs to happen is trusts, rather than trying to just plug the holes in the boat, need to just completely start again and start actually investing in more training pathways, because I think, like Mo had said, there is plenty of work to go around. Like, we are not like sort of sitting there twiddling our thumbs. We could certainly be fine with minimum staffing and a team of PAs on every single ward and still have stuff to do. I think the issue is there's just no commitment there to actually put those training roles out, to employ more people. It seems to be just getting away with kind of as little as possible, which, you know, may work in the very short term, but it seems, I mean, when I started medical school 8 years ago, this wasn't really even a discussion about competitions and the kind of crazy bottlenecks we're seeing. There was like a 99% employment rate outside of medical school. There still is for F1 and F2, but that's kind of got a question mark next to it at the moment. But certainly for specialty training now, plenty of my colleagues really want to start specialising, but just can't get a place. So they're just kind of stuck in a bit of a limbo. Basically what I've chosen to do, locum for a year. But they're just not making those training places. So you are just ending up with these kind of really difficult situations. And unfortunately, it seems like PAs are the ones that, you know, whoever it is poking the blame at. But I don't think that's reasonable at all. I think what they need is that better kind of investment and commitment to actually, you know, put those places out.
Yeah, and I think it all comes down to funding, unfortunately. Like, it happened in my department where, unfortunately, so we used to have 2 F1s, complete training pathway. We'd have our supervisors. The issue is, it's not just about just money. It's also, you have to get this person that you're going to train. They're going to need regular meetings, checkups with the supervisor. So now you need to get a consultant to supervise them. And then the consultants are like, I'm already really busy. It's not like they're hiring more consultants to do this job. They're just trying to get the consultants already there who are already busy to now supervise another student who they're not able to do. So then they try kind of doing other things. So like my trust ended up cutting some of the F1 doctors. So I went from 2 in my year. Now the current F1 is only 1 on vascular surgery at the hospital I was last year. And it's not because, again, it's not because someone else is taking their job. It's just because they don't have the funding and they don't have the staffing to create a new training pathway or continue the training pathway for this doctor. So ultimately, it all comes down to funding, unfortunately.
And it's the same with registrars. So registrar is just before, so basically anything specialty training. You go for your foundation years to your registrar years. There are plenty of registrars that are at the level of consultant, but again, they're not put in the consultancy post. So you basically have to wait for someone to die or retire. So you literally do come across, certain surgical things, people waiting 5, sometimes even like 8 years at that kind of peak level of training just to get that post. And they can't then supervise people and train new doctors until they are a consultant. So it's all quite kind of red tape and bureaucracy kind of hinted. But yeah, it's just a bit...
Sorry, I think we're going to have to cut this one short, just so we can get to our other topics as well. Does anyone have any quick questions about this topic? No? Okay, so thank you to our peers and doctors and pharmacists for sharing their input on that. I think what I've gauged from this conversation is that we just need to share more awareness of what the distinct roles are and the fact that they really shouldn't be compared because they're 2 different roles at the end of the day. And now that you see the healthcare professionals actually talk about their own experiences, it's not how it is online. So I think social media can really take things out of context as well. And from what I'm hearing, it's all okay in the workplace most of the time. So that's really great to hear as well. Moving on to our next topic. This will be very relevant to you, Razi, and Samaya and Leia as well, and our students here. As students, we also play a vital role in working in a multidisciplinary team. We often go on placements, volunteer, or even have part-time jobs in various healthcare sectors. Do students here have a job as a healthcare assistant? Yeah. Pharmacy dispensers? No. Do anyone work in a pharmacy part-time? Yep. So we sort of get to experience what it's like to be in such settings prior to qualifying. However, there's a common sentiment on social media where students sometimes feel like a burden to healthcare qualified professionals. This is more of an issue during placements. For our medical students, Razi as well as Leia and Samaya, to what extent does this resonate with you? Have you had any personal experiences where you felt this way, or do you feel that your experience has been different to this?
I find this topic really interesting, actually, because when I was in third year, my first placement was medicine block. And it was like my third week, I think, was cardiology week. And we rotated in different wards for each specialty. And I remember going in with my clinical partner, and we went up all nervous, you know, found the doctor, and we went up and introduced ourselves. Oh, I'm Leah, I'm Mariam, and we're the medical students. And he basically just pointed to two doctors at the other side of the room and was like, oh, that's Tara and Charisse, they're the F1s, don't bother me. And I was like, oh, okay then. And I didn't go in for the rest of the week. Now, I didn't go in not necessarily because I was so like upset about it or I didn't feel welcome. No, I didn't go in because I had stuff to do. Like I had to revise. In medical school, it's hard having placement 9 to 5 every day. There's things you have to do outside of it. So I took that opportunity to revise. I was like, I'm very happy not having somebody on my back about where I am all the time when I know I need to do revision. I'll go in when I need to go in. And I went in for sign-offs that I needed. And I went in and I had some heart murmurs, but I think it's about dealing with the cards that you're dealt. Of course, you didn't need to be that rude about it, but I don't think it's a big deal, to be honest, not always being expected to be there 9 to 5, to be completely honest. And I think it's just about making the best about that situation.
So I have a different perspective because I did pharmacy and then now I'm doing med. So placement as a pharmacy student was very different to placement as a medical student. Personally, as a pharmacy student, I enjoyed it a lot more. I felt that the pharmacists were a lot more, they were just a lot more willing to help you. They would sit down with you. They would go through things with you. And I do think that's because there was just a lot less of us, and there's quite a lot of pharmacists. So you could have one student, one pharmacist, and just shadow them the whole day, and then they would go through like how to do a TTO. They would go through the bloods of a patient, and it was a lot more fun, I think. And I got a lot out of placement, and I think it was because we didn't at Birmingham, we didn't have to have like certain sign-offs or anything like that. You were actually going to placement to learn. And so I really, really enjoyed placement in pharmacy school. Med school is very different, but I think I have a different experience as a grad medic compared to like the younger lot. I think sometimes when you're a grad, because you're a bit more mature and you're already a bit more confident in a clinical setting, and you're kind of, like all of my friends are grads, we're just not afraid to look stupid. So I will go and ask, even if it might seem like a silly question, I will go up to the doctor and be like, no, can you re-explain that? Or I will go to the nurse and I will be like, I don't understand anything that's going on. Do you have the time to explain it to me? Or I will just say, listen, like, we don't want to bother you because I can see that you're really busy. Is there something else that you'd like us to do? So a lot of the time, sometimes they've been like, okay, look, here's patient notes, go through it. Or if there's things that you don't understand, come and like speak to us about it. And because obviously I'm a bit older, I've learned like what works for me really well. So I'm not like an Anki warrior. I don't do flashcards. I don't do any of that. That was not a thing when I was in pharmacy school. So I learned by doing things. So like what I'll do is I'll like go look at patient notes, and then I will like go through their bloods, and we'll try to come to a diagnosis before we actually see what the diagnosis is. So we kind of use placement. Even if the doctor's not available, nurse is not available, we'll still find something to do, but it will be something useful to help us learn and revise, because I have a very strict, like, after 6 o'clock, I'm not revising kind of rule. I'm going to do my own thing. So if I can get the most on placement, even without a doctor there, I'm more than happy to do that.
Oh, I think that's...
Yeah, but I feel like in medicine, it is hard, and sometimes you do feel like more of a burden. I think it's because you're there for so long, and like I was on surgery block and you're there for 12 weeks. As a pharmacy student, I think you're there for like 2 weeks maximum at a time. So it can just get quite long, and I think doctors can sometimes get a bit annoyed at you. But it's just, yeah, like Leia said, it's about dealing with the cards that you're dealt with.
So I have quite firm opinions about this, and I want to preface this by saying, once again, I really do truly believe that you can't look at doctors as like one entity, because there's a whole spectrum of doctors, and a junior doctor compared to a consultant who's been working for 15 years and just hates his life, very different people. Okay, and I think you or I or anybody who's in that field needs to appreciate that as well. And I think it's really, really important that we kind of use our common sense a little bit. Now, for example, I'll never forget my first day of placement in second year. It was second year. It was my first time, really being on a ward in a hospital, and I was like, all right, this is cool. I'm in a hospital. I can do whatever I want to do. I can help out. And I remember I was on the coronary care unit, and a STEMI patient came in. So it's a heart attack patient, and they were, it was a crash call. They came straight in, and there were like 20 people around them, and they were doing a million things at once. And besides the fact that I wasn't in a position to help, I recognized that this was not a time for me to be in the way, or for me to go to the doctor and ask for a sign-off, or for me to go to the doctor and ask to be taught about ECGs or whatever, right? And I think it's a very similar thing, no matter what stage you're at. Like, if you're at a stage where you want to do things, it's really important to read the room first. And if you do get shut down by a consultant, as everybody does during medical school, it's fine. Like, it happens. It's not nice. It's a bit of a tough one to swallow. But find the next doctor. Find someone a bit more junior. Find somebody who's lovely like Arthur or Mohammed who will help you. And I think that really helps. It helps your confidence, and it also helps you really, build your resilience as well. We talk about resilience a lot when we think about these things, but it's true. I also think that it's really important to also not belittle yourself. So I saw something on social media quite recently where it was a fourth year actually, and he said something like, nowadays, when I introduce myself to the doctors, I introduce myself as a senior medical student rather than just a medical student, because a medical student, once again, could be a first year who's never seen a hospital before, to a fifth year who's very competent. And I think by you introducing yourself as a senior medical student and doing what it takes beforehand, so for me personally, I like to make sure that before I go into, let's say, geriatrics or elderly patients, I read up beforehand, because I know that if I'm going to go and travel an hour to hospital and spend the day there, I need to know what I'm talking about so I can get hands-on and get involved. Otherwise, it's just a waste of time for me, and the doctors don't want to teach you because they're like, this guy is lost, so what's the point, right? So it's a few different things. I think it's a combination of, other consultants right to shut you down and not teach you? Absolutely not. But it's a system in society. Nothing's perfect. You can go into finance, you can go into whatever you might want to go into. There are always limitations. It's just about how you approach those things. And I think it's really just about your mindset as well, to be honest. I think, if you get shut down, it's fine. Move on. Try and do it again. And if it doesn't happen, then it's fine. Go in the next day. Because that's the best way you'll learn. So that is my opinion.
And I just want to add, just to put a positive spin, that there are so many doctors that don't have to take care of you, that aren't allocated you, that will actually just come if you introduce yourself as a student. Or sometimes they actually just see you and they're like, oh, you're the medical student. And they'll just take you under their wing. And just shout out to those doctors. There's loads of doctors, I'm sure other healthcare professionals as well, that are like that, that don't owe you anything, that will just come and teach you, either because they're in that position or just they're passionate about teaching.
Thank you. Does anyone want to share their experiences or how they feel as students? Yeah, I think we've got someone in the back.
I would say to ask them is generally a good way. So you can just say, like Sumaya said, just say, I can see that you're really busy. I don't want to be an obstruction. I do want to help if I can, and I do want to learn. What do you recommend? Sometimes I'll refer you to a colleague that's less busy. I've had doctors say to me, I'm really sorry, it's so busy today. Any chance you can come back in on a different day, or just come back later today at 2:00? So in terms of actually doing something and learning, I would say to ask them, because they'll give you an answer, and they'll be happy to be asked as well, rather than having this awkward situation where you don't know what to do and they feel bad that they can't help you. In terms of getting the sign off, again, you can ask, is there a good time for me to get this sign off? Sometimes they'll sign you off a little bit earlier when it's more empty. And when they have more availability. But at the same time, if you have to get that sign off, you have to get that sign off. You have to ask for it. It's not your job to be worried about people not being able to sign you off. If you need to get the sign off, get the sign off.
Okay, sorry. I think we're going to have to move on from that, but it's just nice to hear other students' perspectives as well. Thank you for sharing that. Thank you also for asking questions as well. This is the last bit now, last little discussion. So, Dr. Arthur, Dr. Mohammed, you're both doctors, and Dr. Mohammed specifically, you always, like, on your social media, you mentioned the difficulties of actually working as a doctor. This is relevant to everyone here as well as healthcare professionals, even as students. Sort of more in terms of, like, personal, like, seeing, obviously, patients dying, seeing all, like, breaking bad news to patients' families. How do you, all of you, how do you deal with that? How do you sort of, not dissociate, but kind of like recover from that? Do you ever recover? What is the sort of, how is it?
I think it really just depends how you are as a person. I feel like with me, I'm good at dissociating. If something happens in a hospital, I'm not going to take it back home with me, even though I've had some crazy experiences that I'm sure Dr. Arthur has as well. You know, like, for example, we had a patient who suddenly died on our ward. First time doing CPR on the patient. The consultants, the registrars kind of knew it was a difficult situation for all the juniors, so they gave us an extra, 45-minute break. We got to sit outside in the park. So, like, people around you do try to help you. In terms of actual things you can do in the hospital, there's a lot of services you can access if you want more help, if you want someone to speak to. You can speak to your supervisor. You have 2 supervisors allocated, and then there's also a service in the hospital that you can speak to. And there's always people to talk to, people who've shared the same experience as you, senior doctors who, sometimes even occupational health. You can go to them and they can, I've had a few people who got really stressed at work and they're signed off, for example, nights. They don't do night duties, or they don't come in on on-call days because they've gone through such a stressful situation where they can't handle it anymore, and they have like regular follow-ups and checkups with these kind of people. So there's always support if you need it, and if you're lucky enough not to need it, then I feel like it just depends on how you are as a person.
I feel as well, like, so, yeah, I mean, just to echo what Mo said, like, there is some very difficult things. I mean, particularly at a young age, in your 20s, seeing a lot of death. There are kind of times in the job where you do kind of just reflect and think it's kind of a bit weird that you're seeing all this, and it does hit you a bit. But I think the way I certainly get through it, so I want to go into paediatrics, and a lot of the time people say about paediatrics, oh, isn't that really sad if you sort of lose children, things like that. But you've got to remember that if someone dies, and you've got to tell their relatives that they've died, or if you've got to tell someone they've got cancer, or if you've got to see someone die and try and resuscitate them, that's going to happen regardless. They're going to find out, they're going to be told by someone they've got cancer, they're going to be told by someone their parents or their child has died. The thing that I take from that is I know that I can try and make that experience as untraumatic as possible for them. I can do the best job I can in that experience. And actually, although it's a very difficult thing to do, and I don't enjoy it, and it's something you kind of do dread and have a bit in the pit in your stomach for several hours until that relative comes in or something like that, they're going to find out that thing regardless. They're going to be told that news. So knowing that you can do it well, knowing that you can be a positive towards that horrible, traumatic thing is kind of how I certainly get through it. And I think that really, since I've sort of adopted that mindset, maybe the last year or two, not really struggled. As Mo said, I don't really take much home. I kind of leave it at hospital. Very rarely tend to dwell on things. And then when I do, seek help, chat to people. No one's going to think it's strange that you want to chat about, a young death or a traumatic death or something like that. It's completely normal.
Just one last thing. It's never actually normalized. So, like, you think, oh, this guy's been a doctor for 10 years. Death must be normal. Death is never normal. Even, like, senior colleagues, consultants, they're just as shocked as we are when someone dies. So it's never that it'll feel normal. It's just you know how to cope with it. That's really the big difference here.
Thank you so much. We're going to have to end there because is everyone really hungry right now? Okay, a big thank you to all our panelists today. We've covered a lot of ground today and discussed some important points. It's been insightful to hear from our audience as well and our healthcare professionals. This is what healthcare is truly about. It's literally listening to each other, understanding each other as different backgrounds of healthcare professionals and understanding each other's perspective. I think it's really reassuring to hear that we are in the same boat and we all have the same mutual feelings and perspectives of a lot of things, so that can be very reassuring and essentially help us provide better outcomes for future learning as well. So please can we give a huge, huge round of applause for our speakers. Thank you, guys. So this is the end of the discussion. So just briefly, there's the networking lunch now. Please use this as an opportunity to, speak to each other. This is a networking part of the conference. So talk to each other. There'll be a lot of people that you may not know. Talk to the healthcare professionals. And then afterwards, we will be ready to start the Healthcare Nutshell quiz, which is, the prizes are really good, guys. So make sure you stay for that, and also the QR codes as well for your certificates of attendance. That will be given at the end. Shortly after that, we'll be doing the closing remarks, and we have a little presentation from our sponsor, Revised Pharma, who also has an exciting little thing that he's going to do, not trying to give it away. And yeah, let's please make our way swiftly to the back. If anyone has any allergies or anything, please make sure you consult with Folu. He will be dealing with all the food and stuff outside. So we will be back here at, sorry, what is the time? 10 past 1. 10 past. We'll be back here at 1:40. So please